Come on, one volunteer, please. Joan. No, vente de paciente, pues no quiere nadie.
Nobody wants to do it?
We got it last Zikri.
Okay.
I
can do it. ¿Quieres que conecte la...?
De momento no. Primero vamos a hacer la exploración biomecánica rápida.
¿Los dos zapatos o solo un pie?
Sí, los dos, ya que estás.
We have that one for our.
Ok. Bueno.
We have a patient. Zikri.
Okay, we have a patient? Okay. Yeah, you can do it. Yeah.
Thank you.
For example,
Yeah.
we do have
Lay down. Okay. Excuse me. Okay, first of all, we have to know if the ankle joint has proper movement. We have to reach at least 90 degrees in this position and 110 degrees in this position. If we feel that the ankle movement doesn't reach the proper 110 degrees, that is around here, the patient will have problems in the final gait, in the final phase of gait, the push-off phase, because in the push-off phase we need to have the proper grades. Then only doing this kind of test we can assess if the patient will have an equinus behavior of the foot. Okay, first one. Second one. The mobility of the first metatarsophalangeal joint that I explained you that is important to know. This is the Danamber test. The Danamber test consists in grab the midfoot, press with the finger the first metatarsal joint, and then develop the dorsiflexion. With this technique, I am doing the similar behavior of the push-off phase. My finger represents the ground reaction forces, and my other finger represents the effect of the ground in the hallux. In this technique, the proper grades to have or to reach is around 50. And this is important to have a goniometer. Do you know goniometer?
Yes.
Yeah, you set the goniometer here with this with the one arm in the metatarsal bone and the other arm in the proximal phalanx. Then grab the goniometer with your hand and with the foot, press the first metatarsophalangeal joint and do the movement. And he have to reach at least 50 degrees. Okay. Third, first metatarsal bone mobility, the least frank mobility. The first metatarsal bone is not in this joint. The first metatarsal bone mobility belongs to least frank joint. Then you have to grab from second to fifth metatarsal bone strongly, and then grab the fifth metatarsal bone and do this movement in the sagittal plane, dorsiflexion and plantar flexion. And the proportion used to be 1 to 1. 1 to 1. If I have 2 and 1, you have an hypermobility. 2 to 1, hypermobility. Or you can have a normal mobility in dorsiflexion and I don't have any plantar flexion. It's dorsiflexion position 2. Is the same bad circumstance to have hypermobility than don't have any plantar flexion movement, okay? And in the opposite way, you can have a normal dorsiflexion mobility and hypermobility in plantar flexion is pathological too. And in addition, the third possibility is to have a rigid plantar flexion, and I can't develop a dorsiflexion movement. This is a rigid plantar flexion position of the first metatarsal bone. That is problem 2. It's the same, no, it's not the same, but it's the same problematic aspect to have hypermobility than to have a rigid mobility. Okay? Position, yeah. Thank you. The next test, Kelikian test. If we have a claw tooth or hammer tooth deformity, we can assess the mobility if to assess the rigid or the flexible behavior in this circumstance, but also we can press beneath the metatarsal head doing the Kelikian test, and with this Kelikian test we can assess how my claw fingers straight with this test. Okay? The fifth mobility is the same than in the first mobility of the first bone. Grab from 4 to the first metatarsal bone, and the fifth metatarsal column do this mobility. Always the mobility of the fifth metatarsal bone is 2 from 2. The proportion is 2 and 2. Okay? If we feel that 1 on 1 is rigid or semi-flexible, but the optimal ways is 2 and 2 proportion. Okay, stand up, please. In order to know if our patient has a pronation foot or a varus or supination foot. Come with me. Don't go. And let me marker. Yeah, yes, this one. Thank you. Thank you. Turn around. Okay. Let me your right heel. Let me. Let me. Yeah. Okay, that's it. Okay, that's it. Relax. Okay. You have to draw the proper dissection of the calcaneal bone. Okay. And sit down, please. Sit down. Let me. And you have to localize the navicular bone. The navicular bone is close to astragal, to talus bone. This is the tibia, this is the talar bone, and touch. And when you feel the shape of another bone, this is the navicular bone. Then set the navicular bone. And now, stand up, please. Let me white paper or one of this paper. Yeah, yeah, this one.
This one.
Okay, thank you. Okay. I sit down again, please, excuse me. Okay. The patient set his rated foot. You have to be sure that the foot is not in supination position or in pronation position. You have to set the foot in the neutral position. How do you know that I am in the neutral position? Because the tibia is perpendicular to the ground, okay? Not that. Straight, perpendicular to the ground. Then, with my marker in a perpendicular way, and following the marker of the bone, of the navicular bone, I set the marker in the paper. And after that, stand up, please, and set the foot in the same. Okay, that's it. Yeah. And now, draw again the point. If the sit down, please. Thank you. Sit down. If the distance between 2 points are higher than 5 millimeters, you will have an overpronation foot because the 2 points that represent the navicular drift is separate too many millimeters, and that means that the foot is height pronated position. And the other tool is stand up, please, and turn around. And the other tool is to assess the calcaneal line of valgus of varus in order to assess if we have more than 4 grades in valgus, is a pronated foot, 0 grades, normal foot, and only 1 grade of varus is a varus foot, or supinated foot. And thanks to that, I can develop a filter, a felt, with more thickness in the medial side or in the lateral side, depends on the foot. In pronated foot, you have to develop a felt with increased thickness in the medial side, and if you have a club foot or supinated foot, the highest increased felt, it will be in the lateral side in order to recover the straight position. Okay? Let's test the plantar pressure. Joan, dame los fieltros, porfa. The felt.
Your friends go to restroom. By
The felt? Ah, yeah, okay. Ah, okay, that's it. That's it. Yes, that's it. And the t-shirts? Thank you. Come with us here. Let's to assess the basal pressures of our patient. Okay, very good. Okay. First of all, yeah. First of all, the patient has to be empty their pockets. The gold medal, the Rolex, and so on, keep away. Why? Because either weight in the pockets modify the pressures. Now, okay. Second step. Second step. The patient has to be in the relaxed proper position. Then I ask the patient, walk on your feet, walk. Okay, and stop. In this way, the patient adopts his proper and natural position. And now we can assess or we can see if the patient has any red color or any orange danger color in his forefoot. In that case, he's a healthy patient, then we don't have any problem. But we have represent now a pressure point with the marker, and we are going to do the felt therapy. Come with me. Okay, sit down, please. No, lay down. Lay down. Yes, better. Okay, thank you. For instance, imagine that we have an ulcer in the plantar surface of the firm metatarsal bone. Then, first of all, we set the plate and we have to cut the felt to cover the forefoot area.
Up to the midfoot.
Yeah, more or less. By the way. Thank you. Okay. Again, test. Okay. Okay. And now, okay. Now, when we are located the hole, we have to round the shape, the width of the filter, of the felt, in order to avoid the edge, to improve the share of the pressure, and in order to increase the adhesive behavior of the felt. Because if we have edge on the border, we can remove too early the felt. Okay, let's do test again. You can hear, you can see, excuse me? Yes. Here you can see the circle of our upload effect. Here is. After that, it is like this, and now I don't have any pressure beneath the first metatarsal bone. As you can see, here is the hole. Okay? And after that, you have to compensate the position with the heel pad, and it's already to walk and to enjoy the life. Okay? Hacemos lo que hicimos ayer de darles filtros a ellos y que practiquen.
Si quieres hacer un análisis, porque les gusta muchísimo, quieres hacer un análisis estático a uno y les
Vale,
el botón.
vale.
Tiene que bajar un momento. Can you get up just for a while? Okay. Okay. We are going to do and this is just in real time, okay? But then we can do a scan, analysis static. We can show you analysis static and dynamic one, and the equilibrium if you want. But let's start with the static analysis, okay? So you can wait for a while just here, and when I told you, just go up, okay? Let me see. Solo puedo verlo en
la pantalla.
En la pantalla grande,
Yeah.
aquí no lo veo.
Vale.
Es un poco. Okay, now you can stand, okay, ready. Just stay here, scanning. Okay, 100% is done.
Okay.
Right? So very easy, and it's the last one. This is the last one. Okay,
Yes.
you can see the
Yeah, this is-
day, the hour that
Yeah.
you do it now. So here you can write your comments. So the patient tested, blah blah blah, the name and everything. And let's go. Okay, let's see. Okay, and then just click here. And this is the static analysis. So, well, Ruben will explain it better than me, but the pressure points, you can check the
Yeah.
kilopascal area on that point.
Yeah.
So remember that he explained more than 300.
Touching or move with the mouse. You can localize the area that you want to know, and to set the kilopascal values. As you can see, he has 18 kilopascal. It's very good.
And if you go down, yeah, there's more information about the left foot, contact surface, right foot. Well,
Yeah.
here's going to explain.
Yeah, the pressure distribution amount percentage is very important to know if the patient has some lower limb discrepancy, lower limb asymmetry. The ideal amount. Hello. Oh, it's finished. Okay, we are. The normal area or the normal distribution is between 50-50. No more than 55 and 45 is the classical distribution. Higher distribution, like 60-40, it will be difficult for our patient because it represents a lower limb discrepancy. In another way, the center of pressure is the maximal point pressure spread on the foot. One foot, this is the center of pressure of the right foot, and this is the center of pressure of the left foot. As you can see, as the red color is located in the left heel, the most highest value in the center of pressure is beneath this, there. 124 against 30. You can see the difference. This is the equilibrium point between the left and right foot. This represents the center of equilibrium of the body.
It's your center of mass.
Yeah, thank you, thank you. It's between both feet. Sometimes you can see the center of pressure displacement to the left foot or to the right foot, but normally it's in the middle of the two feet. Excuse me. Also, you can assess the total area, the total amount of forefoot pressure, the total amount of the forefoot pressure, right side and left side. Normally, the percentage of pressure in a static way is located in the rear foot because our weight is from our head to our heel. By this reason, the most pressure is located in the rear foot. In addition, it's normal to find that the red color area is located in the heel by the reason because our weight is from our head in the perpendicular line to the ground, and the ground is in the heel. This line, the shadow of this line is beneath the heel. Then it's normal to have red color in the heel. It's not normal to have a lot of red colors in the forefoot because the forefoot is forward of the line of the weight. And no more in static way, no more. ¿Hacemos algo dinámico?
Yeah, we can test the dynamic one. The same patient or a new one?
Yeah.
New one. Okay.
Okay, let's go.
Okay. Well, just let me say that this is the static one. Okay. Well, if you go. Okay. Okay. Now I have to go back. I have to go back here.
Wait.
Oh, sorry. Sorry. Oh, now it's disconnected. Oh, disconnected. Okay. Now it works. Okay, it must be green here, so it's done. So sorry. This is the static analysis we made, right?
Yeah.
So if you go here, you can download it in PDF, and you will get a report like that one, for example. Okay.
Cógete el micrófono.
So you can get. This is mine. So I did it before. So this is mine, but this is a PDF. You can download the PDF with the. So you can put the weight of the patient, the height of the patient. Yeah. Okay. So you have. Sorry. We have all the information here. And all the information summarized, right? So this is the PDF you generate. Okay, let's do the dynamic one. First, I'm going to explain you how to do it, okay? And then we will do it. So you have to go. So the patient must stay at the left side of the platform. Just do one regular step that side. Turn 180 degrees and do a right step on that side. As much natural as possible, okay? Because if you do like this because you are scared or something like that, then the pathology will be so wrong. Okay, so I will touch the ready, and you can do it. Okay, let's do it with the left foot. Start with the left foot. You can start with the left foot. Okay, just turn around and do it with the right foot. Okay, and then we just have to wait. Doing the analysis. Done. Charging. Okay. The dynamic of the last one is
This
the
one.
dynamic one.
This one.
okay?
Okay.
It's the hour, everything. You can take your notes, okay, download it and everything. We are going to check it. Okay.
Okay.
Your turn.
Very good. Okay. In the dynamic structure or dynamic study, the normal behavior of the food has to be the maximal pressure area in the forefoot, because the forefoot is the maximal propulse area of the feet. Then it's normal to localize the red color. The important thing is not to have more than 300 kilopascal unit. And you can test the pressure. He is not a diabetic patient, but if he were, ¿y si él fuera? Sí, he were, no? If he was, thank you. If he was, we will have a problem with his central metatarsal bones, because as you can see, the maximal pressure point, the maximal peak pressure is under 300. That the reference tell us that is the high risk ulceration.
I got a question. Say now if non-diabetic patient, like he's an athlete, he's a marathon runner, does it an athlete because they run will it be pressure more on the forefoot?
A ver, repeat.
Like he's not diabetic,
Yeah.
but he's a marathon runner.
Yeah.
So because
yeah,
of
yes.
his attitude
Yes.
of running,
Yes.
will the
Yes.
pressure be
Yeah, problematic, yeah.
so any precautions for him in his running?
Yeah, for sure. For sure, you have to discard this area. We have to know why this area is so charged, so low. Maybe he has hypermobility in the first metatarsal bone. Maybe he has an echinus forefoot deformity. Maybe he has a loss of fat pad area beneath the metatarsal bones. We don't know the etiology, but for sure we have to act there, because if he is a runner, we need to discard this area if we have to avoid the overload metatarsal heads and metatarsalgia and so on. Yes, for sure.
Any suggestion? What should I do? I am a
Let's
marathon runner.
let's explore. Let's do the bed and let's explore. Yeah.
The mic is ready.
Okay, perfect. By the way, an important thing, you can see this line? You can see this line? This is the most important thing that we have to assess in the dynamic study. This represents the route of the center of mass, center of pressure. The center of pressure is the maximal el recorrido.
Yeah, the root.
The route that our center of pressure follows. Thank you, in the cycle of gait. As you can see, this line is not in the center. In what side are? In what side is? Yeah, it trends to the medial side. If we have a center of pressure line with a medial side displacement, it means that his foot is like a pronation foot. Yeah, that's it. Because the normal route of this line, it will be in the center or in the lateral, even the center lateral, and here the displacement, it could be from lateral side or central side to the medial side, and after that goes from the hallux. But he has always a medial side displacement. And by the way, another important thing, when we finish the push-off phase, the maximal pressure point, it could be in beneath the first metatarsal bone and first pulp hallux. If we can't see that his line is in that area, here and here, it may be done because he has and hypermobility first column. As the first metatarsal bone has hypermobility, maybe this metatarsal don't receive any pressure or a little pressure. And by that reason, it could be the highest point of pressure in the metatarsal central bones, in the center metatarsal bones, excuse me. And we can assess. Okay. We want to know if the first metatarsal bone has hypermobility, right? Grab the second to fifth metatarsal, grab the first one. Oh, surprise. Look, more than two, in proportion, more than two mobility. He has an hypermobility dorsiflexion first metatarsal bone. By this reason, as the first metatarsal bone doesn't assume any work, the work is beneath the second and third metatarsal bone. And by this reason, he has a red color and the maximal central pressure point in the center metatarsal bone, because this hypermobility. Okay, very good. Now, do you imagine that we have a ulcer in the center metatarsal bone? Then let's go to discard this area. Tell me the field, the felt. The felt? Okay, thank you. We want to discard the central metatarsal bones, and we want to increase the work, increase the activity of the fifth metatarsal. Then I am going to do a felt with a fenestration, a central fenestration in the central side of the metatarsal bones, and in the first metatarsal bone, I am going to do a felt with high thickness. Okay. Okay, set the template, assess the forefoot area like this. Okay, first step. Assess again. This. Okay. You have to check the hole doing this technique to prove continuous where the hole it will be located. Okay, like this. This. Okay. Okay, perfect.
Very high risk.
Okay, perfect. Now I have the central metatarsal bones discard, but I want to increase the pressure beneath the first metatarsal bone, right? Okay.
Masuk main yang hypermobility dia itu kan. pronation depan.
No.
Tapi tadi left side. Right side.
Okay, let's do test again. The dynamic, another dynamic test. The dynamic, John.
Oh, pijak. Just go to the left side, same as before. Okay, when I touch the ready button, so now you can start with the left foot first. Okay, and now do it with the right. Okay.
Okay. Let's see.
Just now it was my left foot.
Last one, right?
The
This
first
is the left, but you need on the right foot.
Ah.
the left foot, not the right one.
Okay, anyway.
This is the right.
Okay.
Okay.
Yeah.
Oh.
We can, yes, we can diminish, we can decrease, we have decreased the red area. And if you can test here, in the central area, we have only 150 kilopascal, not 300. Okay? And good.
Well, just let me show you one thing because
Yes.
so there's only the previous test. So I mean, we have the previous test.
Ah,
here,
yeah.
So you can check
The right. Okay.
foot on the first test.
Okay.
It's the left one and the right foot. Yeah. That's,
Okay,
and
you
here-
can see. You can see the kilopascal data. Yeah. It's not magic, it's science. Yeah, yeah. Very good. Yeah.
how it steps.
Yeah. In the same, at the same way, in the right foot, the medial displacement of the center of pressure is the same medial side displacement. You have a pronation foot. Yeah.
Even this is also more to the central is more the central more to the medial.
Yeah. That's it.
So
Yeah.
memang you ada pronation.
Yeah, with this felt, we have only discard the central metatarsal head, but we can develop a felt with a more higher thickness in the medial side in order to modify this line. Let's do. Come with me. Let's do it again. And we are going to set another felt in the medial side. Thank you. Okay. Okay. Let's do.
Kalau dia speed tu.
Ada tak you pergi test license? Dia orang ada kedai where they test your food for archery. Tak ada, dia boleh jadi. They have, you go at 6, they have a shop where they test your food. Try them. Then they will suggest you because you pakai tu lari. So maybe you do.
Okay. Let's test now. Okay. Dynamic test again.
Let's start with the left foot. You can start. Now the right one. Usually the second and the third time the patient does it is better than the first one, because the first one people is scared to touch it, and yeah, it's more natural. The second and the third one. Doesn't appear.
Yeah.
Maybe we have to.
No, we
let's do
can't.
it again. Let's do it again.
Yes.
Okay, you can start with the left foot. Start. Okay, now with the right foot. Okay.
No. Why?
I don't know what happened.
No, what a pity. Yeah. No.
No?
No, no.
Okay, let's do it. Let's do it again. Sorry. But you can start.
Yeah, okay. Now. Left.
Right foot.
Yeah, right foot, please. Okay. Remember, can you put the other one, image it? This line run here. Now is run more central. If you remember, can you
Yeah.
Here you have the real demonstration. Then this is not a subjective action. We don't work with subjective emotions or subjective thinking. We have a real tool to assess the scientific results with our intervention. You can do the proper displacement of this line doing filter therapy with diabetic foot ulcers patients, or with sport patients or something like that. You can demonstrate even not only for your experience, but also with the patients. You can say the patient, look, this is your foot before my intervention, and this is your foot after my treatment. Then even in this kind of flat foot or high pronation foot, our experience and our treatment are highly demonstration. Okay?
Also, the podiatrist can develop specific insoles, a tailored insole for that patient. So just following the data the platform offers you, or the platform has, so they can develop a special insoles with, I don't know, metatarsal discharge, or for the pronation, more arc, less arc.
Yeah.
So just following the especially for runners, is
Yeah.
important.
Yeah.
And I don't know if you want to talk about the 3 rockers, because then you explain the third part, right?
Yeah,
About
yeah.
the ulcers.
Yeah. In the heel rocker, we are in this phase of the dynamic gait, and here you can have the highest point because we have the lower limb in the air, and here you impact with the ground. And by this reason, okay. By this reason, pointer here. Thank you. You can see the peak of pressure that is higher than the rest of the plantar of the facet of gate. We don't have any touch. Now touch with the ground, increase rapidly the pressure points. Do with me. This phase, you touch the ground with the heel and press the ground. This is the first impact. This is the first impact, and you follow the impact. You follow the impact and keep the pressure in the same level, more or less. Here is the points. You can have 2 or 3 excuse me, 2 or 3 points of pressure, and as much as you advance in the gate, more pressure contact with the ground you have, because you increase the surface of your foot with the ground. But the reason, then you can see the decrease of the pressure. In the next rocker, the ankle rocker, or the full contact time, where you contact the feet with the ground in forefoot and the rear foot, here you have the full contact time. When the foot contact with the ground, the ankle is in the central area. Here you have the points of pressure that is less than heel, more or less. Here is more than 80 active sensor, and here only we have 70. And the pressure points represents the full body weight in the full contact phase in this ankle rocker gait, here and here. And the forefoot rocker, where you can detect that your heel is on the air, the heel is unloaded, but your full body weight is in the forefoot area. In his case, in the central metatarsal bone and in the hallux. By this reason, the forefoot begins to assume the full body weight, then the pressure increases dramatically here and here, and corresponds with the forefoot central metatarsal bone, and by this reason you can see the point of pressure in this central area. And when the forefoot begins to far away the ground, the pressure decreases. Okay, this is the three classical rocker: heel rocker, ankle rocker, and forefoot rocker. Okay, and following the color area, you can see if the patient has or not has a wrong red colors or not. It's not common in this phase to have a lot of pressure in the central metatarsal bones. It's not common. If you detect a high pressure in this area, maybe the patient has an echinus behavior, for instance. And as I told you before, if you have here a metatarsal bone color and not red color in the first metatarsal bone, you have an hypermobility behavior. Okay?
Let's start with the real patients.
Yes.
Otherwise, we won't
Yeah,
have time
for sure. Yes, for sure.
Okay, so we have the changes in the flow. Since we have two patients today, so we divide
Perfect.
all of you into
Perfect.
three groups. So the group is divided into 5 rows. I mean, like the first and second row will be in group 1. The third and fourth row will be in group 2, and the rest will be on group 3. Okay, are you clear? So while taking turns, you can also watch the demo through our YouTube live stream. Okay.
with interesting wound also.
Yeah.
Yeah.
Very good.
One like this.
Kecederaan.
One like this. The other one, the ulcer, this area.
Yes.
And the remaining one, I'm not sure which area of the ulcer.
Mm-hmm.
So we have prepared the dressing set. I think
Okay.
should be enough lah.
So
Okay.
you want to use the new set, or I think you use the new pad
New fat.
Yeah, new.
because
Yes, yes,
that I
yes.
asked.
So we just
Yeah,
open
yeah.
this.
Yes,
Okay.
Then
As well.
Well, I saw it.
So the thing is now, the guy said that he adjusted to his also. But the thing is now, he's walking. Almost as if moving.
is the new one.
Okay.
This is the new patient for this patient.
Okay.
Maybe group one.
Okay. Okay. Hello. Good morning.
Okay, group 1 can come to the front.
One open.
Can you remove the shoe?
Buka kasut.
Okay. Okay. Take off another shoe. Joan, dame estático. Estático. Me da igual. Vale, vale. Okay. Come with me, please. Come with me. ¿Ya? Ya. Yeah.
Berdiri tegak, tegak. Berdiri tegak macam biasa pada berdiri. So yang ni ditunjuk mana tekanan atas kaki.
Ok. ¿Lo grabamos para ver la diferencia o así vale?
Si quieres los escaneas.
Sí. Ah, vale, ok. Take off. Get off for a while, please.
I'm going to scan. Just a second. Okay. Here. Now you can stand up.
Now?
Stand up. Stand up. Okay. Done. And just as much natural as possible. Okay.
Okay. Come with me.
Yes.
This one. Lay down, please.
Duduk atas ni pula. Baring atas. Duduk.
Tolong assist patient.
Okay. Let's see. Okay. No, relax, relax. Okay.
So just stand there. You don't want to put pressure on the injury. So the center.
Group satu. This, yes. These two adalah group satu.
That's why it's important to the patient stays. You put all the
Okay. This one. Okay. This one.
sini lagi nampak.
Okay. Okay, I need. Joan, ¿cómo se dice para trapo? Strip? Strip? Like this? Strip? Something to fix?
Hay uno que está jodido, ¿eh?
Sí. And he has neuroischemic disease, neuroischemic ulcer. Okay, thank you. Okay. He has a normal mobile behavior, then we can be a little bit aggressive with the felts. Okay? The felt? Yeah. Okay, perfect. Thank you. The marker, please. The marker. Thank you. One of the most complicated thing that we have in this kind of patient and this kind of ulcer is that we have to remember where is the ulcer located, because we have to cover the ulcer with a sterilized gauze in order to avoid the infection. Then I have to develop the filter of loading therapy, remember the ulcer without see the ulcer. Yeah, that's it. Okay. rounded the edge. Okay. Let's see. Okay, let's test. Okay.
Okay.
Okay. Otro estático, Joan. Joan, otro estático.
He visto, el primero no es que sea muy fiable, que se ha apoyado todo en el pie bueno.
Anda. Bueno, pues bueno.
Bueno, pero también lo puedes explicar que, ¿no?
Ya.
Tener un dolor o jodido el pie derecho.
Yeah. Yes, we have a little mistake because the patient in the first step, in the first record, he has avoided the load in the right foot because he knows that his worst foot is the right foot, and by this reason he has a load in the left foot. It's an artificial left foot load.
It's not a natural position because all the pressure is on the left
Yeah,
foot.
and the right foot.
Then look the center of mass, right?
Yeah.
All the body is
It's
on the
put
left
on the
side.
left side.
Yeah, because probably he feels pain on the right one, and
Yeah.
he put the balance on that
Yeah.
side.
But anyway, let's to record and to verify the effect of our filter.
So we just can compare.
Yeah.
¿Análisis o solo que se suba para verlo en tiempo real?
Sí, lo segundo, que se suba.
You can stand up.
Stand up now? Stand up?
Berdiri biasa. Berdiri biasa, Pakcik. Pijak boleh betul saja.
Pijak dengan kaki yang sebelah kanan.
Okay, it's enough. For me, it's enough. Because you can see here the off load. Here is white. It's a total discard. Okay? It's a total discard. Then come with me. Now we have only to add a new filter over the first one. Is only repeat the same filter design. Bless you. Okay. Just repeat the same design. Okay, perfect. That's it. And we have to cover the heel. In this kind of huge ulcers, you can do a whole foot felt. It's not needed to separate the forefoot felt with the rear foot felt, but anyway. Okay.
Tienen dos pacientes más,
Sí,
¿vale?
sí.
Pero en unos 45 minutos tenemos que acabar porque hay plegaria a la una. ¿Vale? Hay que gestionar
Vale,
el tiempo.
vale. Thank you. As he are wearing a special shoe, is not need to add another filter. With one filter is enough. Okay? Let me the bandage. Thank you. Okay. Thank you. In addition, if you want to prove, you touch the plantar foot surface and you can feel the discard. You can feel the air and you can feel the pressure surrounding the ulcer. Okay, enough. Thank you very much.
Mana dia punya plastik? Oh, dah tutup.
Okay.
Sebab tu recap cakap dengan saya.
Thank you. Okay.
Sorry, Dr. Tadi.
Sí.
Hoy es viernes y el viernes es como un día de,
Sí, sí,
más
sí.
de plegarias.
Sí, sí, sí.
O sea, tenemos que acabar puntual. Hacemos los dos siguientes. Okay. Continue with the second one.
A little bit second question.
No,
Y 25 años.
no, no. Que ese modelo no tiene nada que descargar. No worry, don't worry.
Oh, tak payah buka lah. Tak buka. Nak kejap dulu.
I will. Come with me, please. Come with me. Okay, thank you. Thank you. Straight. Okay. Lay down if you are comfortable. Lay down. Lay down. Yeah. And relax. Okay. Okay. So interesting ulcer. Because. Relax. Relax. Okay. If you can see, here we have a plantar flexion of the first metatarsal bone. It's too easy to detect. Relax. Come with me, come with me, come with me. That's it, that's it. Relax, 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 relax. Okay. Has a normal range of motion, but his position is in a plantar flexion. Then we have to do a filter, cover the second two fifth metatarsal bone and retrocapital. Okay? The felt. And this one, yes, this one. Yes, and the felt too. Let's see. Let's see. Thank you. Okay. Okay. Good. Strip. Put you. Thank you. Okay, thank you. Remember always to cover with Stralis gauze the ulcer or the pre-ulcer skin. All actions are always good actions. Okay, and now here, okay. Here, and another one. Relax, please, relax. Okay. Okay, to save time, I don't do the previous basal measurement assessment, but anyway, let's do test. Static, Joan? Yes, sí. Okay, stand up. Yes, stand up, please.
No. So, ¿vas a hacer escanear o solo?
No, solamente de pisar.
You can stand up. Stand up here. Just looking in front. Show me with no shoes. Just look front, you're as natural as possible.
Okay, perfect for me. Look, the effect of my pad. This is the effect of my pad. Perfect. You can see the white color because this is no area, pressure area. Okay, then it's okay. Come with me.
Right now or
Again, see, to fill with another filter. Yeah.
I was mentioned that this patient has a bilateral wound previously,
Uh-huh.
but the other one has already, like the wound is already completely healed.
Yeah.
But maybe they are afraid of any deformities on the heel, the other side. So maybe you want to check whether.
Okay.
Yeah.
Okay.
Just in case
Okay, and the bandage.
ini kecil ya kan, ini kecil dia pasti ada. Betul juga. Ada lagi je yang saya kena sedang ni cakap dia dalam dia ada
Ouch.
opsi.
Yeah. Okay. Let's check the contralateral foot. Okay. His problem is not related with the movement, but also is related with the position. Yeah. It's a flexible deformity, but he has a plantar flexion of the inferior metatarsal bone. Then maybe don't use the. Well, we can use the fat pad therapy, but if we have the possibility, we want to do a plantar insert. Plantar insert with a specific unload of the inferior metatarsal bone with arch, because he has a club foot with a very high arch, and design a plantar orthosis, plantar insert that give some pressure, some load on the arch, and some offload in the first metatarsal bone. We want to, it could be a good option to do a plantar orthosis. Okay, thank you. Thank you.
Thank you.
Yeah.
Last question.
Yeah.
Next question. Last question. Grup 3, grup 3.
It's more like a prize, right?
Dah ratus dengan 100 jauh.
Hello.
I want to see you soon.
Oh, okay.
Thank you.
Ini got diabetic ya?
Yes.
How long already?
Huh?
How long already?
This diabetes is like almost like 10 years.
But then you have an ankle surgery as well.
I met on accident 3 times on the same feet. 3 times. My first one is here, second one is ankle, third one is here.
So your wound all started because of accidents lah.
Because of the blood circulation. No smoking at all, no alcohol.
So the accident wounds on heal properly lah.
Okay.
Other than accident wound, everything is healing is better.
lost because of accident or because of
This recent accident lah, happened on February.
Why is he making so many accident?
Huh?
Motorbike ah?
No, this one is just I got just like accidentally kicked on the signboard. I slip from the floor, get down from the stairs, and slip and went. Just like step on the kicked on the signboard.
You have to be careful removing the previous felt. Thank you. How many days have you kept the felt?
Say again.
How many days have you kept the same felt?
The dressing
Yes.
and then the fleet, everything I change like
Every day?
daily, yeah.
Every day, okay. Okay. Okay, thank you. Let's see.
Actually, this wound, it's already healed. This is the third time. It's opened back again.
Yeah.
It's closed, and
Yeah.
after that it opened back. It's
Yeah.
closed and open back. It's closed and open back.
So when something happens
Like about after 1 month.
after by itself lah,
Yeah.
because of conflict of pressure.
Because that day it was like completely healed, no wound at all. So what I do, I never put anything, never even put any gauze or anything. I just like normal walk, everything. And then instantly I just opened.
Where you following up?
Okay, I have two places to follow up, one in Ipoh and one here.
People, but not the GH.
How long are you diabetic patient?
10 years.
More than 5 years of evolution with vascular disease, neuropathy disease. Is a high risk patient. Okay. Okay, let's do the scar. The felt. Okay, thank you. Let's see. Okay, let me think. Yes.
No,
let me
these
look.
shoes I just will wear today. I have another shoes which is customized only for the leg. But today I never. I was rushing just now.
Let's see.
Yeah, I see that's also. So even I can sit on the top also.
Vale.
Okay, right. So what did I put earlier on is a wrong one.
Yours is only become it's like that.
Yeah.
So it's not
Relax, relax. Look, his medial column is so rigid. Then, if I try to reposition the first column as he has a rigid behavior, I will promote another problems. Then, with this kind of rigid column, it doesn't matter. It's better to improve the discard the medial column with loading the other metatarsal heads, not try to change the first metatarsal behavior because it's rigid. Okay, let me check. Static, John? Static, please. Okay, perfect. It's not, yes, perfect. You can see the whole. Yes, you can see the L shape. This is properly the discard. It's effective because I want to say this kind of image. I want to say this shape that is the discard of my fat part of my offloading therapy. Okay, okay, let's go. Come with me. We are at another filter with the same design. To improve the efficiency of my design, okay? Vale. Perfect. Okay, let me the bandage. Okay, thank you. Vale. No, it's enough. Okay. That's it.
Thank you so much.
Thank you so much. Good? Yeah? Okay. No.
No?
No. Okay.